Welcome, friends. Today we have a very special guest amongst us, an old friend and a powerful, fierce, passionate advocate to NTB. Before I introduce you to her, let me share that we have just passed the midpoint. Since all the governments in the world committed to NTB, over 90 months have passed by. 90 months are left to 2030, but the TB rates have not really dipped by 50% or half. And this is a human rights, or a public health emergency, because when we say TB is preventable, it is not preventable for over 10.6 million people who got TB in 2021 as per the global TB report. So today we have Evaline Kibuchi amongst us, who is the national chief coordinator of the Stop TB partnership in Kenya. And for as long as we have known her for so many years, she has been a very fierce human rights and people-centric rights advocate for ending tuberculosis and making sure that health responses are community-centric and people-centric. Before we ask her to speak, I would like to share what she said to us in 10 years back in 2013. So you can imagine the kind of passion which she brings to the table. And this is an article. This was when childhood tuberculosis was really, she and many others were really trying to bring focus on childhood tuberculosis as well as for accelerating response for TB vaccines. And you should see this, because what she had said 10 years ago and how things have changed. So Evaline had said to us, the Ministry of Health needs to increase contact tracing for adults with TB. It is the best way for the children who have been exposed, and it is not happening now. So I just wanted to say, Evaline, before we hear your insights, when we say that we are not on track, and a lot of it doesn't mean that no work has happened. Lot of progress has happened. Lot of your energy and inspirations and insights. Lot of hard work and toil and struggle has happened to make sure that today we have way progressed to some extent on addressing childhood TB. Today we have progress to some extent on addressing contact tracing of people with TB. So what you had said 10 years ago, 5 years ago, in 2018, the governments agreed to provide latent TB treatment to contacts of people with TB. But of course, like in terms of implementation, things be different. So now it is a time for me to be quiet and let us listen insights from the fierce and powerful is the same advocate which we had heard 10 years ago, Evaline Kibuchi. Evaline, you are welcome. Thank you.
Thank you so much, Bobby. And quite excited.
Thanks, Evaline.
Some subjects again.
Thank you. So, Evaline, please let us know where are we right now in terms of ending TB in Kenya, and also you can speak about globally, as you are such a fierce advocate for NTB and you have that context. So, are we really anywhere near the track where we should have been? Over to you.
Thank you so much, Bobby. And allow me to pick from where I left 2013, that's about 10 years ago, and briefly talk about what has happened and what have we done differently. Two things have happened at the global level. One of them is what I would call political commitment. Back in 2018, one of the biggest gaps that we're fighting against was low political commitment towards tuberculosis. As we are talking now, in a few days to come, we are going to be attending the second high-level meeting on tuberculosis that is going to bring together heads of states from different countries to come and deliberate one agenda, how to end TB by the year 2030. That's a great, great leap that has been lacking all through. And we are hoping that if we keep the momentum of the political commitment, then we might meet the target of ending TB by 2030. With political commitment, then we see more funding, we see more new technologies, we see more commitment into research and development. And that's what we have all been looking for. So at a global level, I would say quite a lot has been happening. In my country, Kenya, A lot also has been happening and good news to talk about. First of all, Kenya is one of the only seven countries that have managed to meet the 2020 and 2022 targets with a baseline of 2015, of reducing new infections and reducing TB-related mortalities. To bring this into perspective, in 2019 alone, the country lost 33,000 people, but that has come down to about 21,000 in 2021. That's a huge, huge reduction. And what can we attribute to these changes? One, like I mentioned, is political commitments. With the establishment of parliamentary TB caucuses, where parliamentarians now sit down to deliberate on how they can contribute to TB through advocacy, increasing investments at the country level. That has been a great game changer. And the second one, and the very important one, is community engagement. Kenya in 2018 established what we call the Network of TB Champions. These are people who have had TB experiences, lived experiences, and are willing to use the experiences for two things. One, for advocacy, and two, to engage in community-based activities that have tremendously contributed to the successes that I've mentioned. Of course, the others are the new technologies, for example, improved, we have the now child-friendly, pediatric-friendly treatments. We have better diagnosis, improved diagnosis. So all these combined have seen a great improvement at the country level.
Yeah, thanks a lot, Evelyn. And when you were talking about pediatric friendly or child friendly treatments, it reminded me Kenya was the first country in the world, I think, which had begun the rollout of child friendly treatments when they became available from the science, right?
True. In 2016, yes.
In 2016, that's some time back, but it was such an important spotlight. It is and also it is in a way very sad that the world forgot the children in TB response. And it's only recently in the last 10-15 years, because of people like you, that childhood TB also is getting its due attention. And now the data is also coming up. And of course, we have child-friendly TB medications. For the friends, I should remind that the child-friendly TB medicines probably were being manufactured in India, but Kenya was the first country in the world which began its rollout, which is great. So, and it's very good to hear this, Evelyn, that TB-related mortality and new cases have come down in Kenya in terms of the targets. And let us hope that this also happens in other countries like India and others. But probably there is a long way to go. So I think access remains a very key issue, Evelyn. Like, are people being able to access TB diagnosis? For instance, in India, as per the National TB Surveillance, TB Prevalence survey of the government in 2019 and 2021, about half of the TB, those who had TB, they did not have any symptoms. So basically, it was chest X-ray which brought them to diagnosis. So first of all, is like diagnosis really happening, and is it happening, and how are we diagnosing TB? Are we using sputum microscopy, which is less efficient, and some people may not get diagnosed from tools like 140-year-old sputum microscopy? Are we really deploying molecular tests? Is like WHO says, every person with presumptive TB should get molecular tests. In India, about 23% get that. So 1 in 5. So I understand there's a lot of resource which has to go, capacity building which has to go, but the pace at which diagnosis is improving in high burden nations probably needs to be much more than what it is currently. So over to you to hear your insights on how can we early and accurately diagnose people with TB. So, and of course, a diagnosis is an entry point to care pathway. So that is why also it becomes so much more important. So over to you.
Thank you. I'll talk about success and look at it in different perspectives. I'll talk about social barriers to access. I'll talk about technology barriers to access. And I'll talk about cost barriers to access. First of all, TB being a very highly stigmatized disease, stigma and discrimination is such a barrier to access, even where services are available, because of the fear that when I go and I am diagnosed with tuberculosis, people will conclude that I have TB. Others fear they will lose their jobs. We have seen cases of people being losing their jobs because of tuberculosis. I've seen children being sent away from school because of tuberculosis. So such discrimination and human rights violation are huge barriers to access. The second barrier is that of cost. You see, we keep selling the narrative that TB treatment is free, but it's only free after diagnosis. Before diagnosis, you're not identified as a TB patient. Therefore, you are subject to all the costs that come with diagnosis of diseases. So that has been such a barrier, because before you are diagnosed with that is TB, you have undergone quite a number of tests, which come at a cost. For example, if you go with a cough, first of all, they may think it's COVID, and you pay for that COVID test. They will think it's pneumonia. You pay for that pneumonia test. They will think it's asthma, and you pay for that. You may go for 5 tests before you finally concluded to be a TB patient. All those diagnoses come at a cost, which many people cannot afford. That's a big challenge. And now I talk about the access, the challenge of access because of not affordability, but the availability. I come from a country where we have some far-flung counties where healthcare facilities are not available. If they're available, they're quite far. And so that becomes a challenge that bars many from accessing the diagnosis. However, there are some solutions that are available, but probably we have not exhausted them. For example, where we have far-flung services, we can deploy more friendly and accessible technology. For example, portable X-ray machines. Right now, we have some digital portable X-ray machines, which we have not yet exhausted that. We still have not rolled out at the country level. Yet they are there, they have been approved, but we have not invested in that. You asked me about access to diagnosis. In my country, yes, WHO, we are using the WHO recommended and approved molecular tests. That is a gene expert. However, we have currently been having challenges of stock out of cartridges for gene expert, which has made us fall back to the old microscopy, which we all know that the efficacy levels are quite low, and that they're not able to diagnose or to tell drug resistance. So that becomes a challenge in diagnosing or identifying drug resistance tuberculosis. And this may often go untreated because of using old technology. So in the country, we are still struggling with having high numbers of people who have not been diagnosed with TB. They're just mixing with other people because they have not been diagnosed. We have just about 50% of people who are diagnosed, meaning we have about 50% who have not been identified, again, because of those barriers that I've mentioned about. But I want to mention one very important one: awareness. Bobby, if I am sick and I know where I am sick, I would not sit down in the house to suffer. But because we have not created awareness like we did for COVID, people are suffering with TB, but they do not know that the symptoms that they are going through is tuberculosis. Therefore, they are not going for treatment. So I would say, even as we invest in new technology, in vaccines, if you're not investing in awareness, then we are wasting all other interventions.
Yes, totally agree with you, Evelyn, on this. And thanks a lot for for the way you mentioned about social barriers, about technological barriers, about financial barriers. I think it is so clear and it is so powerfully articulated. So really, thanks a lot for that. Stigma still lurks, and it is such a huge barrier even today. And technological barrier, of course, is huge. About the last part which you said is also so true about awareness. So, for instance, I was talking to someone in Thailand who she's a transgender rights activist, and she said that the donors, the program should be such that we should serve what people need, not what donors indicators are telling us to do. And what she was trying to say is that even the programs need to be people centric. So if awareness is the key issue, that needs to be addressed and responded. So thanks a lot for putting that spotlight on. About shortage of cartridges. You are we had Paul about 2 months back, and it is so alarming to hear that it's still continuing. And so in India, for example, about molecular tests, the most so 23% of the people with presumptive TB, almost more than 1 in 5, get molecular test. So for all the molecular tests, the most used molecular test is TrueNat, which is a point of care and decentralized. So this is a very big help in terms of making it more accessible at primary healthcare level. Right now, I'm at in Nagua, in a village in the on the southern parts of India, and the primary healthcare center which I visited in Matkai had this molecular testing available. I saw the TrueNat functioning there, and a person getting tested and getting the treatment in the same day, which is really seeing is believing. But this is not the situation of every primary healthcare center in the country. So this is really a very good practice example, and I really wish if that is happening. So what I'm trying to say here is that in terms of human rights, in terms of ensuring that every person gets access to TB testing and accurate TB testing, should we have what more can be done to replace sputum microscopy? So we of course need to, before ending TB, we have to eliminate stockouts, shortages. That is for sure. But in terms of tools, should not there be more point of care, more decentralized? Should not they reach out to the people instead of really, Evelyn, having centralized type of a healthcare system? So back to you to hear your insights on this.
Yeah, first I want to acknowledge the improvement or the progress that has been made in that direction of accessing molecular tests. Like you mentioned from the beginning, I've been in this game for quite a long time. I came to the TB sector when at the country level we had centralized services, especially for drug-resistant TB. I remember patients had to relocate to the city, that is to the capital city of Kenya called Nairobi, from their homes that are up to 300 kilometers away, come look for accommodation in the city so that they can access treatment. And they had other conditions. For example, you had to show a deposit of a minimum amount of dollars in your account to prove that you're able to sustain yourself in Nairobi. And you also had to come with somebody who was going to support you in accessing that treatment. All this has changed now. We have decentralized health services, and almost every county has a TB treatment center and a TB diagnosis center. So yeah, that said, we still have the challenges. First, you talked about access to the gene experts. Yeah, we have, the country has, the government has tried to procure gene expert cartridges, machines, which are not adequate. And I do not want to use the word adequate in terms of numbers. It's inadequacy of accessibility, in that you can have 1 or 2 gene expert machines in a very vast county. So the sample networking issue is a problem, where obtaining samples from far-flung facilities that have to be transported sometimes by public means without the proper transportation equipment to ensure to ensure that the sample is still safe by the time it gets to the center, the Gene Expert Center. That has become a challenge. And so the introduction of TrueNut that is mobile, that can be used at a point of care, that will be the most highly recommended. However, we still have that gap. We have not rolled out TrueNut to the entire country, at least to complement the Gene Expert or to seal the gaps that come with the Gene Expert machine. Like I have mentioned before, we have suffered the issue of stock out of the cartridges for quite a long time, I think for over a year now. And this can be addressed by having the more improved technology like the TrueNut and be distributed across all the counties to ensure that every person who needs the diagnosis can access it with a lot of ease.
Yes, thanks. Literally, amen to what you just said. Let us hope that the TB testing reaches everyone who needs it, and that is so important. And friends, just to remind or restate that WHO recommended for point of care test. This TrueNut is the only point of care test which has been approved by the WHO as far as I know, and it's also available through the Stop TB Partnership Global Drug Facility, as well as other molecular tests like what which you just mentioned, the Gene Expert, the LPA, etc. But what the main point is that that we need to have the best of testing, reach out to the people, especially those who are unable or find it difficult to come to the to the testing facilities, or where the supply systems are really weak. We really need to have then sputum sample collection. Evaline, I was speaking to the district TB officer of Himachal Pradesh, which is in the mountains in the country, and he was saying that it takes 5 days through the postal service for the sample to reach the testing facility, and actually it should reach in 72 hours. So basically that even further adds up to the delay. So it is these challenges are also there in countries with the but of course, as Evelyn had pointed out, let us not forget there are extremely huge social barriers and so many other inequities which keep technologies and health benefits away from the people who need it most. And let us not forget about what happened with COVID vaccine, when rich nations had piled up COVID vaccines, and there were so many countries where even single shot was not made available to the people. So for such a long time. So thanks a lot, Evelyn, for bringing in community and people-centric issues and approaches in the center. So Evelyn, I would like to know that to what extent has Kenya and other countries progressed on 146 treatment regime? You know, in India, we are still using the old isoniazid preventive therapy. So there is a 1 month much better therapy which is available. Science has given it to us, but we are not using it since a long time. Then there is a 4-month therapy available for drug-sensitive TB. There is a 6-month one, BPAL regimen available for drug-resistant tuberculosis. But it is not very encouraging to see, for instance, in India, where every person with drug-resistant TB does not get diagnosed. Secondly, those who get diagnosed, so a lot of them are getting the 9 month, I think the 9-month bedaquiline-based regimen. But then there is a significant number which is still getting that almost 2-year-old regimen, which is toxic, where the treatment outcomes are almost half of the shorter one, and the treatment, and it is of course so long and with injectables. And I think these are the gaps which we cannot afford to have if we are really to progress towards ending TB. This is what we believe. And I know you believe it too, but we'd like to hear your insights on to what extent has we progressed on 146. Over to you.
Yeah, first of all, I really want to appreciate the researchers and whoever has been supporting research for these new improved technologies, including the treatments. However, there has been challenges in the speed at which countries adopt this new technology, which is quite disturbing, because if we have better improved treatment somewhere and I cannot access it for whatever the reason, to me, I would look at it as a violation of rights, because we should do whatever is humanly possible to quickly ensure that patients get the most improved, comfortable, efficiency, accessible, treatment that is available. Anyway, having said that, at the country level, we have made strides, but we have not adopted the newest technology that there is. For example, we have been able to adopt the injectable-free MDR-TB treatment. And of course, we were able to eliminate the category 2 of the reinfection for TB treatments. But we are still using the 6 months treatment for the drug-susceptible tuberculosis. And for MDR, we are still using the 18 months treatment. The reason why we have not adopted the new ones, of course, they're not, we cannot justify them, but I'll just mention them. One is that we are still in the process of developing the guidelines and, the framework, the policy framework for adopting these. And secondly, even when we adopt it, we need funding for that, because more often than not, these technologies come in the middle of a financial year. That means we did not budget for it in the beginning. And for the beginning, we rely heavily on donors to support that. And donor support cannot be fully, we cannot rely on that. So I will make 2 appeals. One, a technology, a new commodity, a new treatment is available. Like, we need to stop everything we are doing and ensure that it has come to do what it was meant to be. Like, so much investment has been put in this technology. And somebody or a policy stands in between a patient and accessing that treatment. I would say it's almost immoral, and we need to work on that. Secondly, countries need to own the TB response and have some reserves, to be used in the event that the country gets the new technology in place, so that we are able to roll it out as fast as possible with no barriers. As for TB prevention therapy, yes, we have adopted the 3HP, though we have not rolled it out at 100%. We are still doing it in small scales and scaling up in a bit slow pace, I would say. But we are hoping in the next few years we should be able to roll it out 100% at the country level. We are right now at about 30% in coverage of the TB prevention therapy.
This is so important, Evaline, that 30% coverage of the TB preventive therapy. And let us hope that the new regimens also reach those who need it. There was a good news which I read yesterday, that 55% reduction in the price of bedaquiline by its manufacturers, J&J. But what I was wondering is, look at the profit margins. Like they slashed the price by 55% in a go, because of generic manufacturers are going to produce it even cheaper, perhaps. Let's hope. So let us really hope that we keep pushing and the prices really become down, and and thousands and millions of more people are able to get medicines in the same amount of money, because that is so important too. So Evaline, I know we're taking too much of your time, but before we let you do your important work, can you share your call for the UNHLM world leaders who will be there next month along with you, and any other issue which you would like to raise or put here? Over to you.
Thank you so much. My call to the leaders, my first and very important one, is a TB vaccine. The lessons we have learned from COVID is that we can invest in all public health interventions, but the magic bullet remains a vaccine. We learned that from COVID, we put all the public health measures, we invested in masks, what we're calling the travel bans, curfews, but all that, it helped, but to a very small extent. The magic bullet was a vaccine. So I am calling on the leaders that they make a commitment to make investment in research and development adequate enough to give the world an effective, affordable, efficient, and accessible vaccine. And when it comes out, there should be what I would call equity in its distribution and its access, that anybody who needs it is a priority. We have learned our good lessons from COVID. The second one is, to the leaders, ending TB is a reality. It is possible. If we are able to almost end COVID in a period of about 2 years, we can surely end TB. All what is needed is increased political commitment, increased investment in TB, and most importantly, engaging communities who are the ones in touch with the people who are suffering from this disease.
Yeah, totally. Let's hope that this message reaches the world leaders. We will try our level best, our 2 bits in in this huge campaign to make sure that the messages remain center stage. You're so right that people need to be center stage. All the programs, it's in India we say of the people, by the people, for the people. That is what democracy should be. But the health responses should be like that too, and that is very, very important and central. And COVID has shown us that economy and businesses and trade, nothing can survive unless we have health security for each one of us. So thanks a lot, Evaline, again for your time and insights. It's really always very inspiring and personally very stimulating for me to listen to your insights. So thanks a lot for that. And we really hope that your powerful advocacy is at its very best when we need it most at the next month's UNHLM. All the best, Evaline, and my regards to Stop TB Partnership Kenya and all your team. Thanks a lot. Bye-bye.
Thank you, Bobby, and bye.